do that. I feel like we had a glitch with that at one point. Um,
Someone else.
I did just mark the record button, so I'm not sure if people got notified of that out of curiosity. Okay, great. Um, I was saying at the beginning I was not 100% sure I knew all the features of recording, but did see the button. So yes, thank you for the reminder because as I was trying to make my brain work for the introduction, I forgot to record. So um, yes, we're excited for Dr. Good to present on early psychosis and medical workups today. You can take it
Hello,
away.
everyone. My name is Megan Good. I am an early course psychosis fellow at Beth Israel Deaconess Medical Center and Harvard Medical School. Through my fellowship, I work with several first episode psychosis programs in the greater Boston area, including the Beth Israel Aspire program, the Edinburgh Discovery program, and of course, the MGH Reset program. Today, we're going to talk about the medical causes of clinical high risk for psychosis syndromes and the need for a standardized clinical high risk for psychosis medical workup. This is not a topic that has been widely explored in the literature, but something that certainly warrants conversation and consideration. We will start with a brief review of psychosis CHRP and introduction of the concept of secondary psychosis. We will then focus on the current role of the medical workup in clinical high risk for psychosis care and how psychiatrists approach and conceptualize medical etiologies of clinical high risk. There are many medical causes or comorbidities for first episode psychosis. The next section will review these causes and explain how the medical workup for PhEP accounts for them in the diagnostic process. We will then propose a standardized medical workup for clinical high-risk patients. Dr. Klaus and I are leading a project examining medical comorbidities, diagnostics, and outcomes in clinical high-risk patients, and we will review some of our preliminary results here. Lastly, we'll talk about future implications of developing a standardized medical workup for clinical high risk. You're probably wondering who this gentleman with his cat is. This is Louis Wain, an artist from the early 20th century, and he's going to guide us through the presentation because he is a perfect example of psychosis secondary to a medical condition. He experienced a TBI, and it resulted in psychotic symptoms and altered mental status. And throughout his life and his art, you can see the changes in his mental state as his life and his art progresses. Psychosis is defined as disruptions in thinking and perceptions with hallucinations and delusions as primary symptoms. Clinical high risk are patients who are at a higher risk of developing psychosis due to changes in behavior, functioning, and perception. There are two types of psychosis, primary and secondary. Primary psychosis is due to a primary psychiatric condition, such as schizophrenia or major depression with psychotic features. Secondary psychosis is a result of a medical condition, which we'll talk about more later in the presentation. Here is an overview of the DSM-5 criteria for schizophrenia, which we're all, of course, familiar with. But where our presentation is going to focus is this line right here, which is the disturbance is not attributable to the physiological effects of a substance or another medical condition. This begs the question, what is the difference between primary and secondary psychosis? What exactly does psychosis secondary to a medical condition look like? And consequently, what would attenuated psychosis in clinical high risk secondary to a medical cause look like? Remember that psychosis is a symptom and not a pathology in and of itself. So obviously psychosis can be a symptom of many pathologies, both medical and psychiatric. And with every presenting symptom, as a doctor, I'm trying to understand why the symptom is happening. Upon first presentation of psychosis, a thorough medical workup is invaluable. However, I understand that resources and time are not always there to perform complex medical workups. Often, a good history and physical is going to tell you most everything you need to know. And looking at this slide, this is how I approach a first episode medical workup. And I want to walk you through some of my thought processes from a physician standpoint. So first, gathering a history is so important. The mnemonic that I use when I'm gathering a history is old CARTS, which is the onset, location, duration, character, aggravating and relieving factors, radiation, timing, and severity of a symptom. And some of these are very important in psychosis. So for example, timing. If a patient is experiencing acute psychosis, meaning within the last days to weeks, they had no other symptoms before this, and suddenly they're floridly psychotic. Oftentimes, that's indicative of a medical cause for psychosis. Whereas if someone has psychosis that slowly and insidiously comes on over months or years, that's more congruent with a primary psychiatric condition. Also, looking at the age of a patient is very important. So if a patient is very young, like a young child, or they're very old, that's more likely to, that psychosis would be more likely to be secondary to a medical condition. Whereas if they were in their teenage years, young adult years, that would be more likely to be secondary to a primary psychiatric disorder. A family history is also very important. We know that psychotic illness is incredibly genetic. If a patient has multiple family members with mood disorders, psychotic disorders, if there's suicide in the family, substance use, we know that astronomically increases their chances of developing a psychotic disorder. Next comes an exam. So this is a mental status exam as well as a physical exam. Looking at your cognitive status of a patient is very important. Oftentimes, with medical causes of psychosis, the patient is going to be, their mental status is going to be altered. So they will not know what day it is. They won't be able to tell you the situation. They'll just be completely confused. Whereas that is typically preserved in psychiatric psychosis due to a psychiatric condition. You also want to do a physical exam and specifically a thorough neurologic exam. Oftentimes, psychotic symptoms due to neurological cause will have what are called focal neurologic deficits, and this would be something like gait difficulties or weakness in a specific limb. Laboratory tests are next. I separate the labs that I order into 4 categories primarily, which are screening for basic health, kidney function, liver function, looking at electrolytes, thyroid function, et cetera. Then we also want to look at infectious causes of psychosis, vitamin deficiency causes of psychosis, and then just a broad category I call other, which is mainly like autoimmune labs and things like that. In first episode psychosis, brain imaging is recommended and preferably MRI. However, many patients along the road somewhere have gotten an EEG to rule out abnormal seizures and other etiologies like that. So this is just like, again, this is just like a general medical workup for first episode. And because we're looking at clinical high risk in first episode, we're looking at 2 illnesses that we're sort of assuming are on the same basic plane, our clinical high risk our workup is going to be loosely based on this. But just to remind you, there's no standardized clinical high risk for psychosis workup. Next, we're going to review medical causes of psychosis as well as their presentation and a little bit about their workup as well. Again, I really want you to pay attention on how generally the presentation of secondary psychosis differs from what you would see every day in your practice working with patients who have primary psychotic disorders. How common is secondary psychosis? It turns out that it's not that common. One study we have, the Northwick Park first episode study, looked at 268 patients from the age of 15 to 70 and examined them for secondary causes of psychosis. 3% had contributing medical comorbidities that were believed to be directly resulting in the psychosis. Another study looked at specifically child patients. They looked at 160 child patients, and they found that 12.5% of those patients presented with secondary psychosis, which is a lot more. And that makes sense to me because having younger children with psychosis doesn't follow the typical course of a primary psychotic disorder such as schizophrenia. So I would say the more accurate answer to this question would of how common is secondary psychosis would be not common, but also it's not rare. So if we're thinking about a general population, I mean the general prevalence of psychosis in the population as a whole is 3%. So 3% of those 3% have medical comorbidities that are believed to result in psychosis. However, 12.5% is quite a bit as well. To put that in perspective, according to the NIMH, 12.5% of adults experience a specific phobia in their life. And I don't think anyone would argue that not looking into that further would be a bad idea just because it's a lower percentage. Broadly speaking, again, psychotic disorders can be characterized using primary psychosis or secondary psychosis. Primary psychosis, meaning that the symptoms are secondary to a psychiatric condition. Secondary psychosis, meaning the symptoms are secondary to a medical cause. These conditions present across the lifetime. Obviously, our patients in clinical high risk in first episode are young. But again, what I really want you to pay attention to is how secondary psychosis, what that looks like and how that differs from what we see when we're working with primary psychiatric disorders. The first large category of medical pathologies that can cause psychosis are neurologic pathologies. And these are by far the most common culprits we see in clinical practice. Many neurologic pathologies involve areas of the brain involved in perception and thought. So dysfunctions in these areas often result in psychosis. The first illness is epilepsy. Epilepsy meaning a seizure disorder. Oftentimes temporal lobe epilepsy as well as partial complex seizures can result in psychosis symptoms. Patients can also experience psychosis after they're healing from their seizure or like the period after the seizure in what's called post-ictal psychosis, which is a period where the brain is experienced this big event of a seizure and then needs to recover from that. And oftentimes because it's had a disturbance in functioning, you can have psychosis. Next, space occupying lesions. Usually this means brain tumors. Brain tumors can be primary brain tumors or they can be metastasis or like from other parts of the body that spread to the brain. Psychosis that we see with brain tumors usually is visual hallucinations, delusions, but these patients have an absence of a formal thought disorder. When we do see brain tumors that result in psychosis, oftentimes they're located in the temporal lobe. And one study showed that 20% of temporal lobe tumors had some level of psychosis associated with them. And I want to emphasize that brain tumors resulting in psychotic symptoms are incredibly rare. I know this is something that my patients ask about a lot as a cause for their symptoms. And oftentimes it's just, again, this is incredibly rare. But here is a case of a child patient who presented with brain tumor. They had command hallucinations of the devil communicating with her, telling her to harm herself. They tried to treat those symptoms psychiatrically with medication. They were refractory to treatment, and they removed the mass, and the symptoms resolved. Again, very rare case. Next are strokes. About 4% of strokes have associated psychotic symptoms. A damage to the frontotemporal region of the brain is most often when you're going to see psychotic symptoms in strokes. This is something that I've seen a lot, especially on geriatric psych units, pretty common. Patients here are most likely going to have visual, tactile, and olfactory hallucinations. This is imaging from a 53-year-old woman who had 6-week progressive history of visual hallucinations and delusions. She believed I believe her husband was cheating on her with their home health nurse. And that was believed secondary to her stroke, no history of psychosis before that. And lastly, head trauma or traumatic brain injuries. So TBIs marginally increase the risk of psychosis with a greater increase in people who already have a genetic predisposition to developing psychosis. When you're really going to see psychosis with a TBI is when a patient has a severe TBI with frontotemporal lobe involvement. And these patients often experience persecutory delusions as well as auditory hallucinations. More neurologic causes of psychosis. Multiple sclerosis is a demyelinating disease of the central nervous system. 2 to 4% of these patients will have psychosis. The more common psychiatric manifestation is depression, but psychosis can be the manifesting symptom here. But you're also going to see it accompanied by things like weakness in the limbs, blurry vision, eye pain. So it's not just going to be psychosis, it's going to be psychosis and something else. Delirium is also a neurologic cause of psychosis. Delirium is like an abrupt, like very quick decline in mental functioning, including memory, perception, orientation, etc. The most common scenario of this is like you have grandma, you admit her to the hospital, maybe the ICU, and then she develops hospital or ICU delirium, which is essentially the brain becomes dysregulated because you're in a new environment. Maybe day and night aren't being regulated. So older people, their brain are very vulnerable to that. You can also induce it with medications such as benzodiazepines and anticholinergic medications. The way you fix this is you regulate the person's environment so they're on a good sleep schedule, and you take away the offending agent if that's what we think is causing the delirium symptoms. Psychosis is incredibly common in dementia. In fact, 41% of patients with Alzheimer's have psychosis. And what that typically looks like, sorry about that. All right. What that typically looks like is delusions of theft and suspicion. So patients will present and they'll say, I know there's someone in my house. Someone keeps stealing my keys. Someone keeps stealing my wallet. And they'll develop this very strong paranoid delusion when it's in reality, they're in the early stages of dementia. And lastly, we have Parkinson's, which is a neurologic illness where there's a dysregulation of dopamine in the brain. Patients, you're going to see them with a shuffling gait. They have a pill rolling tremor, and 20 to 70% have psychosis at some point in their treatment progression. What's interesting is with Parkinson's, because these patients often have too little dopamine, we give them medications that increase dopamine. So if you overdo it, you can actually induce psychosis in Parkinson's patients. And Muhammad Ali had Parkinson's. All right, substance-induced psychosis are one of the more common causes as well. Substance use, if you can induce psychosis with substance use, more than likely you already had a genetic vulnerability. Alcohol withdrawal presents with pretty severe psychosis if the person is not receiving treatment. This is called delirium tremens, when the patient is shaking, they're confused, they're psychotic. It's like they're predisposed to seizures. It's a very dangerous position for them to be in. Cannabis, of course, we always talk about how cannabis induces psychosis in our patients, especially high THC products, especially in use in early teenage years. I want to call your attention to Spice, or K2, which is synthetic cannabis sold in gas stations as potpourri over the counter. This is again a synthetic cannabinoid. It is not related to marijuana. It hits the same receptors. It's not the same thing, and it makes people violently psychotic. Amphetamines are another substance that are notorious for inducing psychosis. That can look like methamphetamine, which you buy off the street, or something like Adderall, which is a medication that many patients use appropriately, but also can be abused to cause psychosis. Next is steroids. This includes anabolic steroids, which are the steroids that bodybuilders use to attain a certain physique, but it also includes corticosteroids, which are the steroids you would receive, say, if you had pneumonia and you needed some help recovering from that. If a patient has an underlying psychotic or mood disorder, you can make someone incredibly psychotic and manic by giving them corticosteroids for medical reasons. And I've had patients in the psychiatric unit treating them for corticosteroid-induced mania for months. It can be quite severe. And honorable mention, LSD and MDMA can both produce hallucinations and intoxication, but there's no clear evidence that they induce ongoing psychosis. All right, vitamin deficiency and toxins as causes of psychosis. The vitamin B12 is well documented cause. A deficiency of vitamin B12 is a well-documented cause of psychosis. B12 comes from animal products. So if you're vegan like me, you really have to carefully supplement vitamin D. Oftentimes with this, you're going to see a lot of nerve symptoms, so numbness, tingling, memory issues, and also psychosis. Vitamin D, just to mention it briefly, it has sort of like a tenuous relationship with psychosis. In the literature, there's some evidence that that a deficiency is linked to psychotic symptoms, but for the most part, that seems pretty variable. Next is pellagra, or a deficiency of B3 or niacin. Niacin is found in foods such as wheat, liver, and fish. Pellagra is defined by the 4 Ds, which are dermatitis, diarrhea, dementia, and death. This is the aforementioned dermatitis that you see with pellagra. And then lastly, heavy metals, not those heavy metals, these heavy metals. So heavy metals such as lead, mercury, arsenic can predispose patients to psychosis as well. Infectious causes of psychosis are my favorite. I think these are fascinating. First is encephalitis. So encephalitis, if you see itis at the end of a medical term, it means swelling or inflammation. So encephalitis is literally swelling of the brain. So many pathogens can cause encephalitis, such as herpes, enterovirus, meaning like the GI bugs you get that make you throw up and have diarrhea for a day and then they're gone. Yeah, those can go to the brain and cause encephalitis. That's actually the most common cause, as well as West Nile virus. The presentation for encephalitis often has psychosis, but you're going to know this patient is medically ill. They're going to have a fever, seizures, hallucinations, confusion, etc. And the way you treat encephalitis is you do a lumbar puncture. You look at their cerebrospinal fluid. You look to see what is causing the encephalitis, and then you treat whatever that is. Next is Lyme disease. This is the Ixodes tick. The Ixodes tick is the carrier of the bacteria that causes Lyme disease. Lyme disease, this tick in particular is native to the Northeast, so like Maine, kind of where we are in Massachusetts. And when it bites you, you get a characteristic, oops, sorry, that's herpes. I keep forgetting to, all right, there we go. That's the characteristic bullseye rash that you get with Lyme disease. The way Lyme disease presents clinically is you have just like a general joint pain, fever, headache, just kind of variable. And then it becomes more of a psychosis, cognitive impairment picture. All right, next is HIV. So HIV in and of itself can predispose patients to psychosis. In fact, 0.23 to 15% of patients with HIV can present with psychosis. And what's even more complicated is some HIV medications actually have side effects of psychosis. With HIV/AIDS, you can also, with AIDS specifically, if your immune system is weak enough, it predisposes you to infections from pathogens that otherwise you would be fully protected against with a fully intact immune system. So one of these is actually called Cryptococcus, which is a fungus. Cryptococcus can cause meningitis, which again is meningitis encephalitis, like swelling of the brain and surrounding structures. I actually had a case of this where the patient presented with no physical symptoms. The only presenting symptom was psychosis. This was a 30-year-old female, no psychiatric history at all, brought in for suspected intoxication. Drug screen was negative. When we did our typical first episode workup, they were found to have HIV/AIDS, and we figured out pretty quickly that this is what was going on with the patient. Right. Syphilis is next, specifically neurosyphilis. Syphilis is a really interesting infection as well. Before penicillin, which is the antibiotic that treats syphilis, 10 to 25% of all patients in psychiatric hospitals had syphilis, and that was the reason they presented. Syphilis is known as the great imitator because it spreads everywhere and causes a lot of really random symptoms. And one of those symptoms is it going to the brain. I had a recent case of not recent, I guess like in my training, I had a case of neurosyphilis where a 40-year-old male, married, no history, no psychiatric history, was brought in for decreased need for sleep, calling ex-coworkers on the phone, had spent a lot of their savings, falls, and a lot of issues with peripheral sensation as well as bladder dysfunction. And that patient, even though it sounded like mania upon presentation, was found to have neurosyphilis. So these things do happen. All right, next, briefly review some endocrine causes of psychosis. Endocrinology is a study of a lot of glands in the body that produce different hormones. So thyroid gland, if you have too much thyroid hormone, it results in psychosis, especially in Graves' disease. Thyroid hormone regulates things like the heart rate, energy, temperature. So you think about if you have too much of that, that may look like psychosis. Next is adrenal causes of adrenal causes of psychosis. So the adrenal glands are these little hats on top of the kidney. If you have the adrenal glands secrete cortisol, which is your stress hormone, and aldosterone, which regulates electrolytes in your body. Very, 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 very important hormones in the body. So if you have too much of those, you can cause psychosis. And it turns out if you have too little of them, you can cause psychosis as well. And lastly, we have the parathyroid gland, which regulates the amount of calcium in the blood. If you have too much calcium, you're going to be psychotic. So if you have too much parathyroid hormone, you will become psychotic. Right? Autoimmune causes of psychosis are next. Lupus is a really fascinating illness. Autoimmune diseases are essentially when the body gets confused, and instead of attacking an infection, it attacks itself and makes a lot of different types of antibodies against itself. So lupus, if you watch Health MD, he always says that it's never lupus, but in psychiatry world, it is often lupus. And also our friend Selena Gomez has lupus, and that's impacted her life pretty seriously. I think she's had to have a kidney transplant. But patients with lupus usually have psychosis within 1 year of developing the illness. You often see our rashes on the hands, as well as a facial rash called a malar rash, or a butterfly rash. If you see patients that have this rash or developing rashes, joint pain, cognitive fog associated with those, I really want you guys to think of autoimmune diseases, because this isn't just lupus. This can appear as a whole. This is how a bunch of autoimmune illnesses present. And that's really one way that anyone who's a non-medical professional that works in this sphere could really help with this sort of thing. Next is encephalitis. This is Susanna Callahan. She had an episode of what's called anti-NMDA receptor encephalitis, where the brain essentially attacks itself. It was a Netflix show. This is something where psychosis is a very common symptom. The book is called Brain on Fire. And just quickly, some genetic causes of psychosis. Klinefelters and Turners are both genetic disease. They're not disease. They're genetic syndromes that affect the sexual chromosomes. So Klinefelters, they have XXY, and they're 4 to 10 times more likely to have psychosis than the general population. And the Turner syndrome, they don't have a second X chromosome, so they're X0. And they're actually 3 times more likely than the general population to develop a psychotic syndrome. If there's one that I want you to take away, it's DiGeorge syndrome, which is 22q11.2 deletion syndrome. These patients, 20 to 30% of them develop a schizophrenia-like syndrome, which is fascinating. And they think the reason behind that is because one of the genes that's deleted is one of the COMT genes, which is involved in the regulation of dopamine. So if you lose that ability, it's hypothesized that these patients develop a psychotic disorder. Next is Huntington's, which is another genetic disorder that is where psychosis is very common. These patients often have writhing movements. They lose control of their muscles. It's a horrific illness because it presents when the patient is an adult, and oftentimes patients don't know they have it until symptoms present. But psychosis is present in 5 to 16% of these patients. Right. And wrapping up some metabolic symptoms of, or metabolic causes of psychosis. A pheochromocytoma is too much adrenaline, and that's also secreted by our favorite little hat on top of the kidney. Um, Next is Wilson's disease. It turns out our body really needs copper, and it doesn't need too much of it. And if the body has too much copper, which is what Wilson's disease is, you can't excrete it. It builds up in weird places like your eyes, and that can, in your brain, and that can cause psychosis. There's a lot of different genetic illnesses, too many to name, that increase risk for psychosis. And lastly, porphyria, which is an illness in which you can't break or you can't synthesize red blood cells. So you have a bunch of toxins build up. Henry VIII was, they think he had that, and that's why he made some of his really weird decisions. I don't know. Maybe I just think maybe he was not a very nice person, but porphyria does run in the royal family in that way. And patients with this condition often experience rashes and psychosis, and they have dark urine. All right, next, I want to talk about the medical workup of clinical high risk syndromes. So let's talk about the need for a standardized clinical high risk for psychosis workup. So the idea of a clinical high risk medical workup is based on the model after the first episode psychosis medical workup and diagnostic process, which makes sense given the fact that we are theoretically treating illnesses that lie on roughly the same trajectory. However, given the heterogeneous nature of the clinical high risk for psychosis population and the known fact that only 20% of patients convert from CHR to psychosis, surely there are unidentified medical ideologies in clinical high risk. And we do not know what they are. We don't know what the percentages are. It's just something that hasn't been studied. Therefore, a standardized clinical high risk medical workup is needed to study this. And as we learn more about clinical high risk syndromes, the role of medical contributors cannot be underestimated. As you can see, there's many different medical pathologies that can cause psychotic symptoms, and we know those associations. We don't know those associations with clinical high risk, and that's very important to know. In order to do this, a review of current clinical outcomes and diagnostic behaviors is needed. Ultimately, this could optimize healthcare resources and standardize clinical for high-risk psychosis care in the medical community. I'm happy to say that this project of reviewing clinical outcomes in order to eventually formulate an evidence-based clinical high risk for psychosis medical workup is underway. This is a joint project between the MGH Reset program and the McLean STAR program. We are currently in the process of reviewing records in order to determine what medical workup patients have received, their medical comorbidities, and to what extent patients were involved in the medical system as their clinical high risk for psychosis symptoms presented. Right. Here's our current clinical high risk medical workup that we use at Reset. To be clear, we would not recommend every item on this list for every patient. Part of doing a medical workup is using discretion and utilizing how the patient is presenting to order a more focused workup. We're not just aiming for everything and ordering a bunch of unnecessary labs. For example, I don't think we've ever ordered anyone for a lumbar puncture with CSF studies. But again, we have no idea about the prevalence of some of the pathologies in this population. So this list is extensive, but it is our attempt to be as comprehensive and conservative as possible as we study this population. I'd like to review some of the preliminary data from our clinical high risk for psychosis medical workup project. So as far as comorbidities go, the most frequent ones we're seeing are vitamin D deficiency, obesity, concussions, and asthma. About half of our patients had sought care at an emergency department to investigate their psychiatric symptoms they were having, and 50% of patients had contact with a primary care provider, and of those visits, 80% were for a psychiatric chief complaint. 11% of our patients have had contact with a neurologist either before or after that we evaluated them, and 8% had a medical admission to look at their symptoms from a medical lens and not just a psychiatric lens. And looking at the workup, patients have had 78% have had a physical exam, 79% have had at least one lab. And that doesn't mean that that's like one lab in general. That doesn't necessarily mean it was focused for like a clinical high risk medical workup. 41% have had head imaging and 17% have had an EEG. And again, we have a lot of work to go. These are just some of our early findings to make that clear. Now that you know more about the medical causes of psychosis and medical workup for clinical high risk for psychosis populations, I like to talk about how non-medical members of a treatment team can spot secondary psychosis in their practice. Doing so would allow team members to bring their concerns to the physicians on the team in order to address these symptoms further. And again, I think I'm saying specifically looking at secondary psychosis, but I would argue that this would also likely apply to secondary clinical high risk for psychosis, secondary to medical conditions. So the first is age of onset. Again, if a patient is really young, like young childhood or really old, 40 plus, it's more, not really old. That's not really old, is it? But I'm almost that age. But if they're really young or if they're older, it's most likely not going to be a primary psychosis. If they're in that late teen, early 20s, early adult years, that's more likely to be primary psychosis. Next is the type of onset. If the onset is insidious, so slowly over time, that's more likely to be a developing psychotic disorder. If the onset is acute, like very suddenly over, let's say, hours, days, maybe a week or so, that is most likely going to be secondary psychosis. Next is the type of hallucinations the patient would experience. Primary psychosis, auditory hallucinations are much more common versus secondary psychosis, visual hallucinations are more common. Next is looking at consciousness. So again, secondary psychosis due to medical conditions, patients are often altered. They can't tell you where they are. They can't tell you the situation of what's going on around them. They may not know the date or the year. They just seem confused in general. Whereas even though patients with primary psychotic disorders can have disorganized thought, oftentimes they're still somewhat grounded in reality, and they can tell you generally like where they are, and the timing and that sort of thing. Next is premorbid functioning. This is according to literature, but according to literature, primary psychosis, their baseline functioning is somewhat impaired. Secondary psychosis, usually normal premorbid functioning. Course of psychosis, primary psychosis, you're going to see a remitting and relapsing course, versus secondary psychosis, you're going to see when you treat the medical condition, the psychosis goes away, which makes sense. All right, future implications. So in general, I think having a better understanding of clinical high-risk medical causes is going to allow our teams to work better in terms of like within clinical high-risk programs, but also with other providers in the community. So for example, therapists, you see patients more than we do. Sudden changes in mental status changes, functionality, such as the ability to ambulate. Maybe they do have that malar, butterfly rash, physical symptoms. If you know a little bit about what you're looking for and you can triage them our way, that would be a huge help to the patient and their care. Next is primary care and pediatricians. I think it's really important that pediatricians know what to look for in regards to clinical high risk for psychosis symptoms. And this would also improve guidelines, both screening with questionnaires, but also screening medically as well. If we can have a evidence-based medical workup for clinical high risk, that makes referrals so much easier because oftentimes, sometimes at reset, we'll ask for labs from referring providers if it's a pediatrician. And oftentimes they're very hesitant to do it because they're like, well, it won't get covered. I can't order an MRI. Like I don't have an indication for that. And via insurance, at least. So having screening guidelines would be very helpful in terms of getting patients the care they need and making referrals a smoother process. And then also working with other specialties. Many of the psychotic spectrum disorders are present in genetic disorders that are closely followed by neurology and genetics. And the concept of a clinical high risk in these illnesses is a concept that is not something that, when neurologists and geneticists don't think of these illnesses of genetic illness that they're treating, they don't conceptualize like a clinical high risk state. They know like psychosis is possible, but I think that's like a very valid and relevant thing to conceptualize in these illnesses. So again, like working more closely with other specialties to ensure that they are aware of clinical high risk for psychosis syndromes and how we can best assist them. So in summary, secondary psychosis is overall uncommon with 3% of first episode patients and 12.5% of pediatric first episode patients. Common causes of secondary psychosis include neurologic disease, substances and toxins, vitamin deficiencies, infections, endocrine diseases, autoimmune illness, and genetic syndromes. The FEP medical workup is largely standardized to test for medical causes of psychosis. CHR likely has its own unique associated medical etiologies that we do not have any data or any, we're trying to change that obviously, but that we do not know yet. And lastly, a standardized medical workup for clinical high risk for psychosis is needed for accurate treatment and diagnosis. All right, thank you so much for your time and attention. I want to thank my mentors, Dr. Jacqueline Klaus, Dr. Lauren Utter, and Dr. Sejal Shah, who have welcomed me into the fascinating world of clinical high risk for psychosis with open arms.